child of the body, which nobody really gives a shit about, to be honest. It's like the ankle, and you know what? Who cares? It's an ankle sprain. Get on with it, sort of thing.
Faraz, I just started recording.
Okay, so I'll repeat that
again, so we can get into it.
Sure. So I guess the reason I have a keen interest in foot and ankle pathologies is the fact I'm getting a little bit ticked off and I guess pissed off with people. Sorry to use my language. Is that people think that the ankle is just a sort of long lost body part of the human body. Like nobody really cares about the ankle, you know, and it is just mistreated and sometimes often misdiagnosed or underdiagnosed in terms of what's going on with the ankle. And then on top of that, what really aggravates me is the lack of pain science and psychosocial approaches behind ankle sprains. That's my biggest element and that I'm concerned about in today's literature, because every single piece of literature you read regarding the ankle, whether that's an ankle sprain, whether that's an ankle fracture or syndesmotic injury, whatever it may be, it is the physical parameters that we focus on a lot of. Always, what does this person need to be able to do to return to his or her level of sport, whether that's basketball, football. Notice how I said football, yeah, not soccer, you know. Yeah, just make sure we're on the right lines there.
I hear you.
But that is what I think is missing big time in the literature, and that's why I have a really keen interest in understanding what's going on behind the scenes when we have an ankle sprain. Similarly, like when we have knee pain or specifically back pain. I mean, massive research regarding the psychosocial approach, the pain science behind it, and I think that's where the ankle is missing a big chunk of research.
I think that's so valid. I've even heard people, and perhaps they don't fully understand what the biopsychosocial model means, which goes back to the Ben Cormack paper that he helped write, the Lost in Translation one from last year. But I've heard people say things like, oh, it's an ankle sprain. It's not a really psychosocial case.
Exactly.
You know, the emphasis is like, oh, okay, it's very biological in nature. Someone sprained their ankle. That's exactly why they're in pain. But there's still a whole human attached to that ankle. Right?
Boom. And that's what, again, I'm glad you mentioned Ben, because Ben obviously allowed me the opportunity to write for the BCP, and that's what I did. And it's really important that it's not treating an ankle that's connected to a human body. It's treating a person with an ankle sprain. Do you see what I mean?
Yeah.
There's a massive difference there. And I think people fail to understand that. And it is, like you're saying, often overlooked. And, it's like I said, it's an ankle, you know, bit of taping, couple of painkillers. And after 2 or 3 days of an ankle injury, you should be able to return to the court or return to the football field. I mean, it doesn't work that way, unfortunately, you know.
Mm-hmm.
And that's where I think that's where I would like to take my. I mean, number one, I'm not a researcher. All right, I'm a clinician. I hate research, but I think if we can contribute to sort of research somewhat, or at least have a discussion about it, then I think it's important to spread that sort of message.
For sure. And even if we don't directly contribute to the research, people still listen to physio podcasts. Clinicians still listen to physio podcasts. So it can still sort of reframe how they think about things if the whole source of their information is from the literature.
Absolutely.
So you mentioned how back pain research has a lot of psychosocial stuff going on with it. And it's so true. We all think about the fears and beliefs that people have when it comes to their back and how that might play a role in their experience with their back pain.
Absolutely.
So what are some common beliefs, fears, attitudes have you experienced that people may have when it comes to their ankle that might negatively impact their experience?
It's a fantastic question. And I think in clinical practice, I mean, like I said, 18 years and 10 of those being involved with professional sport. I mean, football. So in a football world, in a sporting elite world, it's a completely different ball game. You know, you're under pressure, you're under contracts. So that psychosocial approach is there, but it's, I guess, more about my next contract or my next paycheck or et cetera, et cetera. So the barrier is a little bit different, should I say. And their expectations are, I need to get back on the pitch as soon as possible. I will play with a bit of pain. I will play with a bit of instability of my ankle. It doesn't matter. Whereas if you look at the normal person, and the normal weekend warrior, or just like myself or yourself, we just play a bit of sport every so often.
I'm quite
there isn't. Yeah, elite level athlete there, exactly. But you know, for us, it is a case of worrying about, okay, how many days are we going to miss off work because we need to provide for our kids, for example. Do you see what I mean? So the belief and the expectations, those ideas, those concerns and expectations become slightly different compared to the elite level athlete, because at the end of the day, we sprain an ankle, we tape it up, we still have to go to work. Whereas an elite level athlete can come off it for 3 or 4 days or a week, depending on their treatment philosophies of their clubs or institutions that they belong to. For me, barriers are massive when it comes to ankle. Number one, the weight bearing barrier is huge. Once you've had an ankle sprain, or an ankle fracture, or even an infection in the ankle, or whatever it may be, the people's perceptions of can I weight bear through my ankle is phenomenal, is ghastly. They just think I cannot put my weight through my ankle, and I have to really encourage them and sort of empower them to say, you had an injury, okay, you're coming off it, you're calming shit down, building shit back up. Great, Greg Lehman. But it's important to weight bear to kind of get that sort of how can I say, regenerative sort of medicine going on, you know, to really stimulate that ankle, because your body of, let's say, a female 47 years old casual netball player who has just sprained her ankle, I say to her, you have been walking on your ankle for 47 years, okay, or 46 years, whatever. So your ankle that's what it's designed to do. It's designed to transfer load or support your body weight. So let's start to encourage you to put some weight through it. Oh no, but you know, such and such told me that I shouldn't be doing it. Such and such told me if I do that, then I'm going to have osteoarthritis. You know, the barriers just go on and on and on, and it becomes the same thing as a knee. It becomes the same thing as a shoulder, you know, because it's the same sort of negative belief system and that sort of fear avoidance and catastrophizing thoughts that become about that I can't weight bear through my ankle because it might collapse underneath me, or my bones are brittle, or you know, your classic post on OA, how we explain things to patients with the knee. It's the same thing. Massive explanations, and I think there's loads of barriers, but I think we can break down those barriers with really some pain science and psychosocial approaches.
Absolutely. The fragility thing is a huge one. So first off, I want to ask, have you met a lot of people that have had these beliefs about their fragility around their ankle, and you've seen them limping perhaps years after their injury or months
100%.
after their injury, when
100%.
in theory healing timelines have already passed and that
Yep.
ankle is healed, but the person is still experiencing pain and limping?
Absolutely. Yeah. Again, that's one of those things. I mean, I had one today in clinical practice who was about, I would say, probably 18 months post ankle fracture. Yes, the physio he had wasn't great. Sort of more, you know, machine based and more passive treatments and stuff. I get that. But still, after 18 months, he's had repeat scans, he's had repeat x-rays to make sure there's no sort of instability, or there's no sort of remnants of fragments or osteophytes or whatever you want to call it in the ankle. So he's got that reassurance to get going. But when you ask him and you speak to him, I spoke to him today, and for half an hour we talked about his dad's bereavement that happened 3 weeks ago. Do you see what I mean? So like, he was talking about 3 weeks ago, my dad died, and about 3 months ago I lost my job. So I'm thinking, okay, hold on a second. Psychosocial, pain science, just talking about what's going on. Why is your ankle not getting better? Where you're doing the exercises, but all these sort of background things are kind of creeping up and maybe interfering with those sort of afferent or efferent pathways that we can call, that are now affecting your use of your ankle. So is there something else going on? You know, that's central sensitization, or whatever word you would like to use. And it is very common. I sat with him, I spoke to him, and honestly, I kid you not, the way he walked in and the way he walked out was completely different. Just because I had given him some reassurance, and I said to him, listen, I understand you're in the grieving phase because of your father. You know, give yourself some time to grieve, accept, move on. It will take a bit of time. It could take 6 months. It could take 9 months. But don't worry about your ankle. You know, it's going to get better. You know, it's past the healing phase. You've had all the scans. You've had all the reassurance from orthopedic surgeons, or MDs, as you call in your country. It's fine. And he got up with a little bit of a spring in his step, which is quite interesting to see, just with a bit of words of reassurance.
Yeah, it's unfortunate that people have that lived experience, but it is really amazing what some good communication and reassurance can really do for somebody. So that's a massive point there. The communication is one avenue that we use to help people get over these maladaptive beliefs that they have about a certain body part, in this case, the ankle. And a lot of people make the note that it has to actually be communication and not talking at someone, which I think is important. Other than that, are there any other strategies that you use to help someone regain confidence in their ankle?
Very good question. And without sounding so, I guess, simplistic, because I think that's what physiotherapy needs, is simplicity rather than all the sort of BS out there. Agreed. I think the most important thing is to actually do it with them in clinical practice. So whether that means actually showing them and demonstrating a visual kind of key, for me, is very important when it comes to ankle. You know, like we demonstrate exercises for back pain or shoulder pain, I think the ankle, because it is the bottom of the body, the foundation of the body, which we can't come off it. Do you know, we need to walk, we need to go to the toilet. We can't come off it, if that makes sense. So I encourage people in front of me to kind of do some visual imagery. I like visual imagery a lot. So follow me or stand in front of a mirror and do something that's slightly, you're going to watch yourself move and see how you can weight bear, or see how you can lift your knee and stand on one leg, or do your wide balance test or SEBT, whatever test you want to do. It doesn't bother me. But I think visual imagery is very, very important when it comes to an ankle sprain, and especially that sort of neural pathways from the brain to the ankle. Although it takes milliseconds, it's still longer than transferring a message from here to the shoulder, for example. Do you see what I mean?
Yeah.
So, or the back, you're going down the sort of central pathway of the back or the central nervous system. Getting down to the foot might take 0.8 milliseconds, but it's still slower than the message from here. So those signaling take time. And I say to them, the same thing, if you kind of avoid sensitive tissue, you're actually going to get more and more sensitive. Do you see what I mean? So you have to load sensitive tissue as tolerated, but it's important that you load it so that your brain understands what the ankle is supposed to do, not come off it and stay there, because it's going to develop some stiffness and some scarring and all those sort of things. And then that vicious cycle of pain signs starts to go again. You know what I mean? So they're my thought. And sometimes I even pull out a paper, and I know that people don't want to see that. It's boring. I'm pulling out a paper, but sometimes I think if I get an educated person who wants to learn, we all know that you'll always put a little bit more effort into somebody who wants to get better. I'm sorry to say, as a physiotherapist, people looking at me, probably thinking, oh, this guy's not a real practitioner, but it's true. You always put in a little bit more effort, whether that means showing them an image on Google or showing them a paper or emailing them a paper to read. You'll always do a little bit more to someone that you know is going to get better, because they're going to listen to your advice and they're going to act upon it. Do you see what I mean? So I might even show a paper or something, but again, I'm not here to bore you with the research, but there is research out there of an ankle sprain, the guidelines, the algorithms. I don't like algorithms and guidelines, sorry. Spit that out. Everyone is different, but there are algorithms, there are guidelines. But honestly, the best paper at the moment, I would say, is probably the PASS framework in 2021 by Smith and colleagues. I don't know whether you've had a chance to read that. The PASS framework is very, very important. Now, the reason I like the PASS framework is it focuses on both. It's probably the only paper that focuses both on physical parameters, but it has that sort of component, the third A in PASS, PAASS, is athlete perception. And it's about return to play following sport. So that athlete perception encompasses confidence, empowerment, mental capacity to return to play, the confidence levels. Whereas other papers, it is all, like I said to you, just about physical parameters. And there's really, really not much about the mental. And that's a paper I show people a lot when it comes to ankle sprains, the PASS framework. The other one is obviously with Delahunt and colleagues in 2019, the ROAST consensus. A lot of people have read that. But again, there's 9 clinical assessments for an ankle sprain, looking at your arthrokinematics, looking at your gait, your posture, but then there's nothing. There's nothing about psychosocial really homing in on that. I thought about it, and I wrote in my blog that there should have been a 10th item to put the icing on that cake in that paper to say, these are your 9 assessment criteria, but the 10th one, don't forget it, it's the psychosocial approach to an ankle sprain. But it's missing again, and that's what we're talking about. So there's a couple of papers that I might show patients who are willing to learn, who are willing to appreciate the science, and also willing to kind of look at both parameters, physical and mental.
Right. Yeah, it's interesting, because when I asked you if there's any other strategies that you use to help them get over their maladaptive beliefs, you brought up exercises, but it wasn't exercises about restoring dorsiflexion or building up the strength in their soleus or improving anything physically.
Absolutely.
Per se. It was more about using imagery to help them have trust in their ankle again.
Exactly.
And I haven't read the papers that you mentioned, but frankly, I would be a bit surprised if they mentioned that the exercises might need to be tailored less for addressing physical parameters, although it's still important to get physical
100%.
adaptations in many cases. Sometimes those that's not what you're using exercise for.
Absolutely.
Sometimes it's to get somebody more comfortable mentally with their body part. Which sort of, I had this talk with Angus Bradley yesterday, and he was talking about how, I don't know if you know him, but he's a strength and conditioning guy. He's great. He's very, very smart. He was saying how, although people won't like to admit it, at the end of the day, fitness, and I think also physiotherapy, there is an art component to it.
100%.
Because there's so much that we don't get from the research like that.
Absolutely. I think, like I said, we mentioned Ben earlier on. Ben had a post a couple of days ago that the rehab that we do for an injured athlete or a fitness athlete are completely different when somebody's in pain, right? So it's the same thing, and that's what it doesn't have to be a physical parameter. It can be just somebody gaining some confidence by visual imagery, by doing it with them. That gives them that reassurance that as soon as they leave the practice, they're on their own. All of a sudden, okay, the physio told me I need to do this, this, this. Stand in front of a mirror. Sometimes I even stand them, and it sounds really weird. Like stand naked in front of the mirror and visualize yourself. How you're standing in front of that mirror. Are you normal? Are you weight bearing left? Are you shifting your body weight? Are you weight bearing through your forefoot or your hind foot? What are you doing? Compared to the right. Make sure you keep doing both, keep shifting that weight and seeing what happens and what you're doing differently. And that's what I think is important. Patients is keep the exercises simple, keep them low level, especially if they've just had an ankle sprain. I'm talking day 1, day 2. I start this visual imagery, whether it's lying down in supine and just asking some, okay, move your toe left and right. Okay, do some alphabet writing. What do you feel? But make sure you're engaging the other foot. It doesn't have to always be straight into a low bearing exercise. You can come off it for a couple of days. That's important. Patients realize that you can come off the ankle for a few days. It doesn't matter. It's not going to kill you. Do you know what I mean? And then you can go back to your normal sort of loading principles when you want to.
Right. Yeah. It seems like mindfulness is a big key in all these exercises.
Mindfulness is key. Mindfulness is key all over the world these days.
Yeah. Yeah. That's so interesting. It's so true how I see what you're saying. I've never really thought about this before, but we do. It seems like think about the ankle differently.
We do.
We really do. Very
but again, but the same thing is with. You can look at. I like to compare the neck to the ankle sometimes, and it's different because when we have, for example, neck pain, what do? You see people coming with this big collar. Oh, I can't turn my neck to the left, and I might get some pins and needles into my arm or some radiculopathy sort of symptoms. Okay. Come off it, and then the weight bearing the ankle, same thing. Let's tape it up. Let's go on crutches. Let's not put any weight bearing through it. So it's not like protective mechanisms, both things. Whereas, when we talk about the elbow, we have a little, let's get a little bit of movement going, or get the wrist. Let's get the wrist going a little bit, But it's the ankle, come off it, neck, don't move it at all, And I'm thinking, hold up a second. They're both normal parts of the human body, but the neck is because it's the neck. It's so close to the central nervous system. Let's protect it. And the ankles are furthest away from the body. Let's protect it again. So it's really weird how we process the thoughts around the ankle. And then obviously we've talked about a couple of papers, but then there's obviously the debate, which I guess you spoke to Kieran a few days ago about the ACL, surgical, non-surgical. The evidence is rubbish for surgical management. It is absolutely atrocious for surgical management. There isn't any severe evidence or really robust evidence to say that you must have a ligament repair or lateral ligament complex repair if you've sustained multiple ligament injury. The results are no different to conservative management or non-surgical management at a year or 18 months. And also
from the little research we have
exactly.
Studies. Yeah.
And the surgical complications are, post-traumatic stiffness of the ankle into dorsiflexion, scarring, potentially the risk of DVT or infection around the area. So those sort of things are surgical. Might have, they say, surgical results in some papers say that they might have a better American orthopedic foot and ankle score. Who cares? Who cares about the scoring system? But ultimately the risks are higher than obviously non-surgical management. So I think that is another thing. Patients come to me and saying, well, I keep rolling my ankle. I've got this sort of mechanical instability or functional instability. Let's kind of figure out what's going on. Whether we need imaging for that, that's another debate and another story. But these two common symptoms that we hear people say, I've got mechanical instability, or the surgeon told me I've got mechanical instability, or is it functional or is it mechanical, or is it pseudo mechanical, is it pseudo functional? It's like, whoa, we just keep asking these questions. But as long as people don't do the rehab properly, starting from visual imagery to then going through those loading parameters to those physical characteristics that we need, whether it's your side hop test, whether it's your vertical jump test, whether it's your triple crossover test, whatever test that you want to mention, there has to be an adequate psychosocial approach and not just a simple, sorry to say, freaking questionnaire. It's not enough. That's not enough.
Absolutely. And it's like, if we go back to the ACLs for a second, when we compare the laxity of the ACL ligament when it comes to surgery versus natural healing, we see that the natural healed ACL is a bit more lax. So we zoom in on that, and then if we only focus on that, we might think that surgery is more optimal.
Yeah.
But we're forgetting about the whole person. Like, does it really matter if this one tiny ligament in somebody's knee is more lax how about we look at the whole person instead and see if there's an actual issue in their life?
That's again, I hit the nail on the head straight away. I mean, and that's the same thing with even with I don't like a diagnosis. I hate the word diagnosis. No, I don't think everyone needs a diagnosis. That's just my opinion. And some people agree with me, some people don't. But same with the ankle, for example. Like, me doing a valgus stress test on the ATFL and you doing it will be slightly different. You might think it's a grade 1. I might think it's a grade 2 or grade 3 instability. All right. And then you go to a radiographer who MRIs it for you. Might be some 2 years graduated radiographer, or might be a 25 years rate, and they might have a difference of opinion whether that's a grade 1 or a grade 3. It's mind-boggling when you talk about what difference of parameters there are in terms of diagnosis and what you think. But ultimately, the rehab is gonna be the same. The only difference will be, as they're saying, elite level athletes is the mindset.
Yeah,
the difference
and also again the pressure to get them back on the field quicker potentially, which might make them get surgery quicker because we're just still in that uncertain phase of when it comes to ACL research specifically.
Exactly, and that's where we are. And I think the same with the ankle. So I think that's where we are with the ankle. I mean, in terms of where we need to go, a lot more needs to be done on the pain science side of things, on the psychosocial side of things, and that needs to be researched a lot more, rather than just thinking about clinical guidelines and algorithms of an ankle sprain, Ottawa ankle score, yes, X-ray, no X-ray. Okay, fine, that's okay. It might be important as well. Or all these things, even the PASS framework or the ROSE consensus that you might read up later on, Noah. They're great papers, they're okay, but they're lacking certain aspects. And that's where I think we need to go. And like I said, somebody might say to me, well, you're talking about it, Faraz. Why don't you bloody do some research? Well, I'm sorry, but I'm not a researcher. I can't stand doing research. But yeah, I'm happy to obviously contribute if somebody wants to do a paper. But no, I'm just not that way inclined, to be honest.
Of course, when I took Greg Layman's course recently, and he said it about 5 times. He's like, "I'll be the 5th author in the paper if any of you wanted to." He kept saying that.
So true.
Yeah,
that's really true.
Yeah. So,
but I'll be interested to what your thoughts. I mean, I don't know whether you know much about Canada, for example, just because obviously that's the part of the world you're in, North America. What is their consensus when it comes to the treatment of an acute ankle sprain? Let's move away from the Rice, Price, Peace and Love. Let's move away from that. So you've got an ankle. It's been, let's say, 3 weeks post grade 2 ATFL, and a bit of bone bruising on the medial border, medial sort of side of the. What's the protocols in Canada? What do surgeons think there?
Surgeons? I don't know if I could speak more so for surgeons. I could really just speak on my own experience.
Sure.
From school and from the clinic that I work at.
Okay.
So from school, the idea would be peace and love. Sorry to go back to it. And with no strict protocol, no exact guidelines. From a surgical standpoint, I work in a multidisciplinary clinic with orthopedic doctors. And I'm happy with the setting I'm in because they try and avoid surgery at any chance they can. Yeah, they one of the doctors that I work with, he says all the time, I just think about myself and I do not want to be put under the knife unless I would need to. So I think the same way for all my patients, which I think is great. Yeah, so if it's a grade 2 sort of ligament sprain, from the physio standpoint, which is what I have way more experience in, most of the people that I work with, for sure, and at least what they taught us in school was peace and love sort of thing. But then I think when we get into the practices of clinicians that graduated 20, 25 years ago, and they don't go on social media and don't follow
the dinosaurs,
people, and they don't read any research, the dinosaurs. Yeah, it might be a little bit different.
Yeah, I think it's the same everywhere. I think it's the same everywhere. Even in the UK where I am, I think it's the same. There are dinosaurs in all professions, and especially in orthopedic surgery, there are dinosaurs. But you can't get that. I mean, and you know what? Some people are actually proud of it. They admit that they're dinosaurs, and they say, you know what? I didn't do 15 years in university to not cut people open, and I respect that. If they put their hands up and say, you know what? I'm a dinosaur. I like cutting things open. That's what I trained to do, and that's what I get paid to do. Hey, you know what? Stand up for yourself. But it's the ones that kind of deny it and say, well, no, I'm not like that. I'm not money driven. I'm not incentive driven. No, I want the best for the patient. And I'm thinking, do you really? But so they're the questions I sometimes ask orthopedic surgeons. But like you said, a shared decision making approach is where we are. But I also sometimes kind of debate that word as well, because I think the more opinions are like arseholes. Like everyone's got one. Nobody wants to hear them. Nobody wants to hear them. So everyone's got one. No, you say, and it's that you're sitting around a round table and you're discussing with an ortho, a physician, a parent, a coach, me as a patient. There's 5, 6 voices already, Yes, it should be a shared decision approach, but there's always going to be somebody with that little bit of a weighted argument. Do you know what I mean? So I think shared decision-making approach, multidisciplinary approach, whichever word you would like to use, are positive, but they can also be harmful as well, in my opinion. Just have to be a little bit careful.
How can they be harmful?
Okay, so we do, you know, with all these studies, you have a general consensus, right? And the consensus is usually kind of a 3-2 or a 4-2. You know, oh, we win because 4 of us thought we should have done this, and 2 of us should have. I think, and that's where again that pain science and psychosocial approach comes in for that person. See, I'm the patient. Whether I'm an elite level athlete or whether I'm a weekend warrior, people need to hear me, what I want to say, what I would like to know, and then I will make my informed decision with all you 4 or 5 sitting around me who are giving me your 2 pence piece. Ultimately, I need to make my decision. I don't want to be swayed by the orthopedic surgeon. You might be using some scare tactics with me. You might develop some long-term OA and some horrible chronic ankle instability, etc., etc. That's going to make me think, well, hold on a second. And then somebody else on the other side is saying to me, listen, I've had this problem for 20 years. I've never had CAI or chronic ankle instability. I'm absolutely fine if you do some. So I think it's great to kind of have the discussion. I think it's important to have the discussion, but ultimately the decision-making power should lie with the patient. And I think sometimes that authority is taken away from the patient sometimes into the hands of the medical providers or the clinicians because they have that sort of, I guess, ego or a little bit of status quo that I'm a little bit more experienced in this than you are. You know what I mean? So I think that's where I think it's like an MRI. It can be helpful, but it can also be harmful as well. And I think there's similar concepts in shared decision-making discussions.
I agree. Yeah. And if people really think that they know best, and even if in their mind they want what's best for the patient and they think they know best, even if it might not be the best strategy, they're still going to bias the conversation in a way that gets the patient to decide on that option. So yeah, it really isn't much of a decision.
Correct.
On the patient, in the patient's perspective.
Exactly.
100% I agree. Yeah. Yeah, that's tough. It's very tricky. So how do we go about improving that?
A good, very, very good question. I think there's been some papers that have alluded to this in ACL and ankle and even shoulder. Like, you know, yes, you sit down, you have an MDT approach, but at the same time, you have opinions, you have a bit of research, and you have a patient who then needs to sit back and say, right, if I don't do this surgery, I'm going to miss the rest of the season. For example, if I do this surgery, I might be back in 3 months. Or I get people who tell me that, you know, I can't afford to do the surgery right now. Number one, I don't have private insurance. Number two, I don't have the monetary funds. Number three, I can't afford to take time off work. You know, I'm going to be off work for 4 or 5 weeks in an air-cast Robocop looking big shit boot like this. I can't take time off work, for example. You know, I've got to cater for my wife who's suffering from stroke or, you know, Alzheimer's or is on long lifetime care, for example. So all these, again, psychosocial approaches come into the forefront again, I think. And I think that's where around that 5-6 people around that table, I think the only person who might experience some psychosocial or pain signs will be the patient themselves, saying, I can't afford to do this surgery right now, Mr. MD or Sir, whatever your name is on the right-hand side. I can't afford to do surgery. What don't you say? Well, you're going to develop chronic ankle instability then. You know, those sort of things are going to say, oh, let's try and respect this person's opinion and say, there's no harm in delaying surgery for a year or 2. What's going to happen? Nothing.
Right.
You know, there's
we're zooming in on the biological, right?
There you go. You're focusing on the biological, which most, and again, no disrespect to orthopedic surgeons or MDs or sports physicians. That's their job. That's their job, is to look at your ankle, knee, hip, shoulder, and say, this is what's wrong with you. Whether that's wrong with you or not, nobody cares. But it's, again, appreciating that psychosocial, wider picture, wider scope of practice we need to look at. And I think that's where a good orthopedic surgeon will say, Faraz, what's going on behind the scenes, mate? You seem a bit anxious about this ankle sprain. Well, yeah, doc, you know, someone told me this might happen. Can't afford to. I've got 3 kids at home. I've got to provide for them. I can't take off 6 weeks from work. Is there any other solutions? Yeah, we could delay this. When's the right time for you? You know, whatever, 2024, February. Yeah, okay. Let's work with that. Let's work with that. Let's work with that. Let's pencil in February 2024, and now let's work backwards 9 months, 8 months, whatever it may be, and let's see what we need to do in that area. Okay. What do you think about physiotherapy? Do you want to do some physio? Yeah, you know, whatever.
Beautiful.
It's a shared decision-making process. You're setting a goal, you're setting a timeline, expectations, realistic, and then you're working backwards to work with that patient. What's wrong with that? Why can't we do that?
Right. Yeah. Just, I mean, again, as you said, it is their job and you need to focus on the biological. Fair enough. But also, it doesn't take too much time. And surgeons are so busy. But if they could just, and it's the same with physios too.
Yeah.
I don't want to say that we're saints because we all mess up.
Absolutely.
But just taking the extra time to say, what do you think about that?
Absolutely.
How does that make you feel? Is this
Yeah.
something you think you'd be able to commit to? Anything like that, just so that the patient can open up a little bit more, so that they understand that it's an option. It's not something they need to do, because it might be the surgeon's opinion that surgery is the best thing for them biologically, and that may be very, very true. But maybe for their life it isn't, right?
Exactly. And that's the thing. I think that brings us so nicely to our point is when I see a new patient who comes in to see me, the first half an hour consultation, there is no hands-on approach. There is no even palpation. It's just a discussion, and people look at me and I'm like, oh, I've got to pay 50 quid for this appointment. This guy's not even touched me, but he's gone out of the room thinking, wow, that was really informative. I know where I'm headed with this ankle pathology. I know it doesn't require surgery. I know it doesn't require imaging. It needs a bit of offloading and a bit of reloading. I'll be back in 6 weeks, hopefully, if my psychological state is right and the club gives me the support that I need, my family gives me the support I need, my office gives me the support I need, maybe 3-4 days off. God, that psychological barrier just gives you that sense of boom, that little eruption that you need to say, man, I want to get back from this ankle sprain. It's not as bad as I first feared, because I've got these sort of components around me that are helping me out. And that's what I do in clinical practice. And people appreciate it, I think, when you actually give them that real spiel and that reassurance in the first half an hour, and then say, next session, I'll have a look at your ankle. I'll get you doing some testing. I'll stand you up on one leg. I might get you to hop on one spot. I'll look at your knee to wall test and see what's going on, So I think that's important in any MSK condition. That first half an hour of rapport with the patient is massive.
For sure. So there's no physical assessment in your first.
No, I don't really. I don't. It depends. If I'm 100%, stone cold, know that this is what the pathology is and this is what the patient needs, I might get them doing some. Obviously, I might do a little bit of hands-on. When I say hands-on work, I mean some assessment criteria, which will involve, some upper limb myotomes or dermatomes, whatever you want to call it, just to rule out anything sinister. But otherwise, it will be a case of getting them doing that. For example, visual imagery. I said that would be my first sort of point of call. Right, let's get you in front of that mirror. Stand with your crutches, lift your crutches up, and stand with your feet like that. Okay, what happens? Okay, great. How does that feel? Yeah, it feels good. I'm surprised myself here. I was like, wait, hallelujah,
Yeah.
Put your crutches down again. Throw your crutches on the floor. Hold my fingers. Now stand there. What do you think? Yeah, I'm okay. I'm a little bit aware of it, but it's not painful. Oh, great, hallelujah. And, just work. And that, by the time you look at your watch, it's like 20 minutes gone, 25 minutes gone. You're like, well done. This is your home exercise program. One exercise, not 12. One, do it properly. That's it. Not a sheet of 7 exercises that patients get confused, don't know how to progress, come back in 3 weeks' time and they haven't got a clue what's been going on. One exercise, come and see me in a week, 10 days, we'll reassess the situation unless anything sinister is going on in that interim period. Pretty straightforward. It's pretty straightforward.
Yeah. I had a patient last week and the whole assessment was just sort of seeing, like, he's very well acquainted with the whole physiotherapy process, and he knows that there's physical tests that you do, but we did not do any of them. We spent a little bit of time in the office that I was in, and then we went right to the gym, and we spent about an hour there together, not just working out the whole time, but it was just exploring. And he asked me the following week, why did I do that?
Okay.
And I said, well, with you, I thought it was all I needed to do. With everyone else, I just use my magic hands and it works great and I just heal them. But with you, I thought it was good because he had all these beliefs, and it's just, I could maybe spend some time stretching his hamstring so he could say ow on the table, or we could just see how much he can move and see if we could do a little more than he previously thought.
Absolutely. I think it's great. And the fact that he asked you a question tells you about the level of the caliber of that patient. Do you know what I mean? Yeah. He's asking you, he's inquisitive. He thought you did something different. What he thought of physiotherapy would be his first session was completely different. So that would, maybe he's seen physio in the past who've done what you've just mentioned, all this physical testing and palpatory techniques and all that nonsense. He's probably been used to that. So therefore you've come in and all of a sudden thrown him a curveball and said, let's go to the gym, let's have a chit chat while we're doing a bit of exploring and movement. And he's asked you that question, which is great, I think. And that's the first point of developing that patient rapport and then moving on to that sort of, exercise-based rehabilitation approach with those chit chats, which are ultimately psychosocial. They're just having a chat and finding out what's happening with this young man. Hey, buddy, how you doing? How was your weekend? Yeah, it's fine. Oh, my old man's sick, whatever it may be. But it's just that chit chat. And that allows the patient to open up, distract them from their main cause of injury, whether it's structural damage, whether it's not. It just gets them a chance to move. And it's so easy. It's not. I keep saying this to everybody. We are physiotherapists. We are not bloody freaking cardiothoracic surgeons, all right? We are just a physiotherapist. Keep things simple. People respect simplicity. If you don't know the answer, just say, I don't know the answer. I don't know what's going on. Why do we need to waffle around it and say, oh, your ankle ligament might be pulling from here up into your sort of perineal area, and that's why your knee seems to be tilted a little bit. Like, who cares? Let's just talk about what's going on. Let's talk. So anyway, I think we're going off tangent, but yes, you can see I'm passionate about foot and ankle. I love a foot and an ankle. And I think it's really, really important to kind of, like I said, get back to the discussion, which was the research is clear, and we need to add a lot more psychosocial pain science when it comes to any ankle pathology, not just ankle sprains. I'm talking about, talus fractures, calcaneal fractures, fifth metatarsal fractures, whatever they may be. It needs to be a lot more, I would say. At the moment, it's probably 80-20. Let's just say that 80 in physical parameters, 20 in psychosocial. I think that needs to be a lot more balanced moving forward.
Right, for sure. Not, and I know you agree with this, so I hope you don't mind if I speak on behalf of you, but not to say that biology isn't important, the biological part isn't important, and that we shouldn't pay attention to any of it.
Absolutely.
It absolutely is. Absolutely. It's just that most of the time, it's all that we focus on, if not, it's most of what we focus on, because we came from the biomedical model. Nobody's saying biology isn't important.
Absolutely.
But you cannot deny that there are humans attached to these body parts.
Yes, that's it. That's it. Punchline. Boom, 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 boom. That's what you just said there. That summed it up. We are anything. Any joint is attached to a human being, all right? So we need to respect that. And I think that's really, really important. Yeah.
Right. So let's switch gears a little bit here.
Go on.
We've been talking a lot about the physio profession as a whole.
Yep.
And probably unfairly bagging on surgeons a bit. So let's bag on physiotherapy a little bit. One of our first conversations ever that we had over Instagram DMs, I asked you if you had any advice for someone who is just entering the workforce, which was me. And then you said something along
change your career.
Lines. You said get out while you still can. Something like that.
Oh, brilliant.
So get out, mate. Don't do it. So I'm curious. Yeah, and then we had a conversation about that. And I think you said something that that healthcare was overrated. And I'm not trying to paint you to have this whole black and white perception, because you're a physiotherapist, and we were just talking about all the good that you can do for people.
100%.
But could you just elaborate a little more on what you were trying to tell me at that time?
Yeah, I mean, look, again, I'm a physiotherapist. I've been a physiotherapist for 17 years, and I'm on my 18th year of clinical practice. I've loved every minute of the journey. Although at some point, yes, there has been physio burnout and feeling of what am I doing? Like all this, false beliefs that I've been led into over the years. And now I'm finding my own way with how the research is changing and how people's viewpoints, not just social media, but people, talking around the topics. I just think, obviously, when we were talking on DMs, it was obviously just a joke. I didn't want to scare you away from it. But yeah, it came across like, this guy's like saying we stay out in the profession. I just think, like you say, because we are taught pretty much modalities, a biomedical approach. That's what we're taught: anatomy, physiology, biomechanics, and modalities, and a few bit of research methods, and maybe a touch of pain science and stuff. So for me, I was never taught that. Mine was all, you're lucky you've had a bit of pain science, and that's great. That's the universities, whether that's in North America only. I mean, I don't think I was in Dubai for 10 years. I don't think they're teaching, pain science and communication strategies in Dubai. And I'm not sure they're teaching it in some of the universities here either. But I think that's where I was kind of alluded to that. I think I would say that jokingly, but I think if we can get the right, how can I say, dynamic and the right sort of teaching professionals to promote the course in a different way and take physiotherapy in a different way, which it is slowly shifting, very ever so slowly, it is shifting. away from that biomedical approach and more a case of talking to somebody, I think I would go back to university and relive my experience of physiotherapy, because I would say now, as I said, I think probably 9 or 10 years of my life in professional football, I believed a lot of stuff.
Yeah.
And I thought manual therapy was the be all and end all. And I thought 80% of my treatment was manual therapy and 20% was exercise rehab. And that has changed probably the other way around, 80-20 in terms of exercise rehab and working more with the psychology of the patient. And that's how my practices, I guess, has differed in the last, whatever, 8 years or something. So yeah, sorry, I'm going off a tangent. What was your question?
No, that's great.
But yeah,
That's
no.
great. Yeah, no, like I knew there was obviously like a joking element to it, and you weren't trying to deter me from doing it. But
No.
I think it is important to acknowledge the pitfalls of the profession, because we want it to improve, right? We're in it.
Yeah.
Yeah,
I think for
I'm
me,
still going to stay in it. So
I think communication is, like I said, we need to, like I said, we need to talk to people. We need to
Yeah.
be better at talking to people. That's the first thing. And there should be a 6-month module on communication strategies and, motivational interviewing and things like that. That needs to be a module, in itself. Whether we go for 3-4 months in university and we learn about that, how to deal with, failure, how to deal with denial, things like that. I think which we don't really talk about. Obviously in medical school, they have, breaking bad news, for example, to a family. That's a module in itself. But how do you break someone has died in your family? How do you communicate that with a patient? That's important. For example, for us, you've got an ACL rupture, and it might mean that you'll be out of action for 18 months to 2 years, for example, or a frozen shoulder. These are the 3 options: a wait and see approach, or physiotherapy, or a hydrodilatation procedure, or a capsular release, or whatever it may be. It's understanding those communication strategies to tell a patient, because usually as physiotherapists, when patients come to us, they've heard something already. Right. That's unfortunately the big bad world we live in. They've already heard from someone, whether that's a colleague, whether that's a friend who had the same pathology as that individual, or whether they've seen their local family medicine doctor or orthopedic surgeon. They've already come with these kind of vast array of ideas of what they think they need. And then that ability for us to challenge those situations and challenge those difficult conversations, we're not trained to do that. We're trained to kind of agree and say, yes, I agree with the surgeon. And yes, you may need some surgical intervention if physiotherapy fails. So I think that's, for me, is a massive, massive improvement that needs to be done through the big institutions around the world.
100%. I've heard a few physios say things like, when there's a lot of psychosocial issues going on with a patient, they'll say things like, oh, I'm not a therapist, so I'm only going to focus on the biological things. Fair enough. We're not therapists.
Yeah, fair enough.
But wouldn't it be great if we had some training in psychology and communication? Absolutely. I mean, there is some in communication, at least in my schooling there was, but in my opinion, not nearly enough.
Yeah.
Because at the end of the day, we're seeing patients a lot more than any other healthcare professional for the most part.
Absolutely.
You're spending a lot of time talking to them. So I think you kind of have to make sure that you're saying some things that are going to be helpful for this person.
Absolutely. And like I say, the toothpaste analogy, once you squeeze out those words, you ain't putting them back in, mate. So that's what I say to patients when I see them. I was like, what the orthopedic surgeon has filled you with, you're going to be with me now for the next 3, 4, 5 sessions, whatever it may be. So, let's work the first session to unravel all that sort of spaghetti junction that you've just been told. That's the first session. Second session, we'll get a bit more confidence and rapport. Third session, we'll start loading, great. We'll start getting a bit more movement into the body, into the human system. So I think that's where I would say physiotherapy needs to change. Maybe it's changing in some parts of the world, which I'm really, really glad to hear that you had something in your course module. That's something that's fantastic. And I hope other universities will follow around the world. But yeah, I think that's, if we just do 1 year, a foundation year on those sort of strategies, dealing with grief, dealing with bad news, communicating, listening skills, why do we have 2 ears and 1 mouth, those sort of things, which I heard all this outside of university. Never in university I heard this sort of stuff,
Right.
Or, when you say hello to a patient, hello, Noah, what brings you to see me today? Shut up. Quiet. For the next, don't interrupt in 20 seconds. Yeah. We're not told that. We're like, okay, where's the pain? Oh, yeah. How long did it start? Okay. Did you have a fall? Or, we just keep on and on with the patient. And they're telling us the diagnosis. We just need to shut up and listen, So I think those things that we're not encouraged enough in the first year of clinical practice, Then I think the anatomy and physiology matters, a little bit of biomechanics. And then obviously this third and fourth year is probably where we need to do the exercise rehab approach. You know what I mean? So I think that would be where I would put my sort of new physiotherapy profession guidelines or module content, whatever you want to call it. But that's where I would say we need to go a lot more with to develop physiotherapists in the future, because you get asked these questions and you don't know how to deal with them. Not you personally, I'm saying young students coming out of university, they're like, I learned this at university, but whoa, that patient I dealt with yesterday, I was almost intimidated. I was embarrassed. I was jealous. I was fearful. I was fearing for my safety because he was a bit aggressive or whatever, because that is real life practice. Not what we see in university behind those blue curtains. You know what I mean?
Right. Where it's just your buddy who's pretending to be the patient.
Exactly. And he's telling you what you want to hear.
Yeah. Right. Exactly. So that you can get a good grade. Yeah.
Exactly.
100%. I was listening about that point on listening. I was listening to Jeff Ford's podcast. He's only had one episode so far, but he had Anthony Wild, I believe is his name. He has his own podcast. I know Wild is 100% his last name because his podcast is called that.
Okay.
Wild Physio. But he was saying something along the lines of, I think it only takes about 20 seconds for a clinician to interrupt. Yeah, their patient when they ask them, you know, what brings them in today.
Correct. It's exactly what it is. It's exactly what it is, and that's what I say to him. I think who was it? Adam touched on it. Adam Meekins touched on it as well. Same thing. He's got a couple of research papers that he showed me when I met him last time. Same thing. We just need to shut up, because and he does a great way, and I think it's really important. He actually mirrors. He uses a mirroring technique, which I think is fantastic. I've learned that from him, where if somebody comes in and they're not communicating with you, how you can break the ice so that they do feed you information. Somebody says to you, you know, what have you come to see me today? Oh, my neck hurts. You're like, oh, okay. It's like a bit of awkward silence, you know what I mean? And he's like, oh, you know, he said, oh, really? Your neck hurts? And he's like, yeah, my neck hurts, and I'm getting a bit of referred shoulder pain and elbow pain. Okay, and you know, okay, the referred shoulder pain and elbow pain. Okay, and yeah, I've had it for about 6 weeks. 6 weeks, you know. So he mirrors what they say, which then prompts them on to then keep talking, which is great because you're not really interrupting; you're just kind of echoing what they said. And number one, it makes sure that patient knows that you're listening. That's the great thing. And number two, you're kind of getting the conversation flowing, and you're still not interrupting them really. So I think that's a great way of doing it as well. And these are things that we're not taught. We're not taught these things. You have to learn them outside of clinical practice in the big bad world.
Right. Yeah, that's a great point. I think that's just better for all parties, because also you're just not even, you don't need to fumble with all of your thoughts and your words trying to figure out the next best question to ask them to really pry the answer out of them. You just need to repeat them, mirror them a bit. That's a good strategy. I got to use that more.
Yeah, it's something I learned recently. I'd say probably motivational interviewing and mirroring patients is probably what I'd say 3-4 years. Just kind of started doing that, which just makes my life a lot easier rather than sit there and say, bloody hell, I'm not really getting anywhere with this patient. Maybe I should just refer on. Like we call it high pass in England, you know, little high pass, rugby pass to the next person, refer her on or refer him on. I'm not dealing with this, but I think that motivational strategy and asking those questions has definitely helped my clinical practice as well.
Yeah, I've heard a lot of my friends complain about those sorts of patients where like you just can't get anything out of them. So I gotta go spread the good news that there's a strategy to deal with it.
That's so true.
Beautiful. Well, I think we're almost out of time here, Faraz, but I just want to thank you for coming on. I really appreciate it, and I appreciate you because we spoke about dinosaur clinicians, and I always appreciate people's ability to change their minds about things.
Yeah.
And I think graduating 17 years ago, or 18 years ago, whatever it was, I'm sure you have had to change your mind about countless things. And I commend you for that, because that's not easy, because our egos are very fragile, and it's always a painful process. But I think it makes the world a better place when we can change our minds, and it's not easy. So.
Yeah, no, I appreciate that, and thank you for having me on. And obviously, these chats are really, really informative and really, I guess, meaningful. And hopefully, they can educate the younger population moving forward into the profession, and even the current people in the profession who might need to open their minds up, because there might be some dinosaurs out there who are physio dinosaurs as well, who are adamant on their techniques working, and they're adamant and their techniques are the best, and the outcomes of patients are the best because of a particular technique that they use. That's fine. We can't really change those sort of mindsets. But I think it's really important, like you said, to just have these conversations, these uncomfortable conversations sometimes they are, you know, to kind of grow and develop as a profession and individuals. And I think that's really important.
Absolutely. Yeah, and they're I've known that they're massively helpful for me. Just listening to people like Jared Powell, like Adam, like Greg, just listening to them speak has massively shaped not just my current thoughts, but more importantly, how I think. So,
critical thinking, right? So I always say you have 3 C's: communication, critical thinking, and obviously clinical reasoning. Those 3 things, if you've got those 3 things in your kind of armory, you're going to be a good professional. If you can do those 3 things well, and not worry about what other people think. But those 3 things, if I was giving the message home to any sort of students watching this or any sort of younger physiotherapists, is that 3 C's: communication, critical thinking ability, and obviously clinical reasoning. And those 3 things will make you a very, very competent clinician moving forward.
Let's end on that.
All right, buddy.
Thank you, Faraz.
No worries.
Stop recording it.